Welcome back to the Deep Dive. Today we're taking a really close look at a single dense textbook chapter. Our goal is to basically transform it into an elite masterclass.
Right. We're focusing on those highly specialized agents that manipulate the central nervous system.
Exactly. We're exploring this, vast landscape of CNS drugs. It can seem contradictory, right? You've got potent stuff causing seizures on one end.
And then these subtle molecules trying to maybe bring back lost memory on the other. It's quite the spectrum.
It really is. And we're defining our scope pretty clearly. CNS stimulants, the drugs that globally stimulate or maybe improve specific brain functions.
And then the cognition enhancers. These are the ones aimed at dementia and cognitive impairment, a huge challenge.
So our mission for you listening today isn't just to skim the surface. We want to go deep. We want to master the mechanisms, the uses, the limitations.
Like, professionals in the field really need to understand this stuff, beyond just the bullet points.
It's about understanding the why, isn't it? The molecular consequences, the reasons behind the prescribing.
Precisely. We're looking at 4 major categories from this chapter, and, well, we have to start at the most dramatic end, the really powerful agents.
Okay, so convulsants. We're talking about CNS stimulants, but powerful enough to actually induce convulsions.
Yeah, and they usually work by messing with key inhibitory pathways in the brain. Brakes, essentially.
Right. So our first example has to be strychnine, the classic neurotoxin.
Absolutely classic. It's an alkaloid, comes from the seeds of the Strychnos nux vomica plant.
And the seizures it causes. They're described as generalized, tonic-clonic, and crucially symmetrical.
That symmetry is the telltale sign.
Why? What's the mechanism that leads to that specific, symmetrical, whole-body convulsion? It sounds incredibly targeted.
It is incredibly targeted. The key insight is where it acts. Strychnine specifically blocks postsynaptic inhibition that's mediated by glycine.
Glycine. Okay, so that's a major inhibitory neurotransmitter, but mainly where? Spinal cord.
Exactly. Spinal cord and lower brainstem primarily. Think of it like this. Excitatory signals are the gas pedal. Inhibitory signals like glycine are the brakes. In the spinal cord, glycine applies the brakes to antagonistic muscles.
So, like when I flex my bicep, glycine tells my tricep to chill out?
Precisely. Renshaw cells in the spinal cord use glycine for that exact purpose. It's essential for smooth, coordinated movement. And the textbook demonstration site for strychnine is right there, the Renshaw cell motoneuron junction.
So strychnine blocks glycine there.
And suddenly, there's no inhibition on those opposing muscle groups. Both flexors and extensors contract simultaneously, forcefully, all over the body. That's your symmetrical tonic rigidity. Catastrophic.
Oh, wow. And treatment is basically managing a massive seizure, like status epilepticus.
That's the approach, yeah. Suppress that runaway excitation.
Okay, that really clarifies the strychnine mechanism and the resulting symmetry. Now, let's switch gears to picrotoxin. Different source, fish berries.
Anamyrtococculus, yep.
And the seizures are different, too. Clonic, spontaneous, asymmetrical, plus vomiting, respiratory, vasomotor effects. It sounds messier.
It is, in a way, and the mechanism reflects that. Picrotoxin also blocks inhibition, but it targets GABA, primarily presynaptic inhibition. But here's the critical nuance, the professional detail.
Yep.
Picrotoxin is not a competitive antagonist at the GABA receptor.
Right. Not competitive. Let's unpack that because that distinction is fundamental. What does binding non-competitively or allosterically actually do at the neuron?
Okay, imagine the GABA a receptor complex. It's got a channel in the middle that lets chloride ions, Cl, pass through.
Negative ions. So they inhibit the neuron, make it less likely to fire.
Exactly. GABA itself is the key. It binds to the main site, the keyhole, and that opens the chloride channel. Chloride rushes in, hyperpolarizes the cell, inhibition achieved.
So a competitive antagonist would just block that keyhole, right? Fight GABA for it.
Correct. But picrotoxin doesn't play that game. It binds somewhere else on the receptor complex, an allosteric site. Think of it like a separate liver or bolt on the channel mechanism itself.
So it binds there.
And physically jams the channel. It prevents the chloride pore from opening, even if GABA is perfectly bound to its own site.
It's like locking the door from the inside, regardless of the key.
That's a great analogy. It shuts down GABA's inhibitory effect by blocking the consequence, the chloride flow. And because GABA is so widespread in the cortex, blocking it non-specifically like this leads to more chaotic, asymmetrical seizures, plus that stimulation of respiratory and vasomotor centers.
And understanding it's a chloride channel issue explains the antidote, diazepam.
Right. Diazepam is a benzodiazepine. It doesn't fight picrotoxin directly. It binds to another allosteric site on the GABA receptor
Yeah.
and makes the receptor more sensitive to whatever GABA is still around. It enhances the remaining GABAergic transmission, trying to force more chloride through any channels picrotoxin hasn't managed to block.
That mechanism antidote link is so clear when you break it down. We should probably briefly mention a couple of other tools here. Biculine.
Good point. Bicuculin is important mostly as a research tool. It is a competitive GABA antagonist. It directly competes with GABA for the binding site, synthetically made.
And pentylenetrazole, PTZ. Sounds like it was used more historically.
It was, yeah. Powerful CNS stimulant. The exact mechanism is a bit debated, maybe direct neuronal depolarization, but also seems to interfere with GABA inhibition, possibly similar to picrotoxin.
But its main role now is in the lab.
Absolutely crucial in the lab. Antagonizing PTZ-induced seizures is still a standard screening method for new potential anticonvulsant drugs. If your compound stops a PTZ seizure, it warrants a much closer look as an antiepileptic.
Okay, so that covers the really heavy-hitting convulsants. What about analeptics? The respiratory stimulants.
Right, the analeptics. Historically, yeah, they were used for things like resuscitation in coma, fainting, respiratory failure from, say, barbiturate overdose, or even severe COPD.
Trying to kickstart breathing.
Exactly. Drugs like doxapram, they do stimulate respiration at doses below the convulsive threshold, acting on the medulla. But the big problem, and why they're basically outmoded now,
The safety margin.
tiny, terrifyingly narrow margin of safety. You push the dose just a little too high, trying to get more respiratory drive, and boom, you tip right over into a generalized seizure.
Not a good trade-off.
Especially now with much better supportive care like mechanical ventilation, we just don't need to take that kind of gamble anymore. They were expedient measures, but not safe ones.
All right, let's shift gears. We're moving away from those dramatic, often dangerous molecular blocks towards a more nuanced class. The psychostimulants.
Yeah, these are more about globally increasing cortical activity, enhancing focus, alertness. The mental effects are generally more prominent than effects on, say, breathing or heart rate, though those can happen too.
We have to start with the big ones for ADHD and narcolepsy, the amphetamines.
Right, you got racemic amphetamine, the D-isomer, which is dexamphetamine, and methamphetamine. These are synthetic sympathomimetics, but they really stand out for their central actions.
Stimulating mental activity more than motor activity.
Generally, yes. And methamphetamine and dexamphetamine are noted for having a higher ratio of central to peripheral effects. More bang for your buck in the brain, relatively speaking.
Which sets the stage perfectly for methylphenidate. Chemically similar, pharmacologically similar.
Very similar in the core mechanism. Both amphetamines and methylphenidate work primarily by increasing the release of norepinephrine, NA, and dopamine, DA, from nerve terminals.
Right.
Flooding the synapse with these key neurotransmitters.
But clinically, there's often a preference for methylphenidate, especially in kids with ADHD. Why is that?
Well, the data suggests it might be a bit better tolerated in some key areas. Specifically, it seems to cause less tachycardia, so fewer issues with rapid heart rate, and maybe most importantly for parents and pediatricians, less growth retardation compared to amphetamines.
That's a huge factor in long-term treatment for children.
Absolutely. And it's effective. Our source material says it improves behavior and learning ability in about 3 out of 4 kids treated. That's a pretty significant response rate.
And it's used beyond childhood ADHD too, right?
Yeah.
Narcolepsy, attention issues in adults.
Correct. But, and this is a big but emphasized in the text, we need to be crystal clear about what it's not for.
Contraindications are key here.
Definitely. These are not antidepressants. They shouldn't be used for depression. They're not for dementia. They're not for obesity or weight loss. And they're not just for pulling an all-nighter if you're otherwise healthy. These are targeted tools.
Got it. What about how the body handles it? Pharmacokinetics.
Methylphenidate is well absorbed when taken orally. The plasma half-life is relatively short, maybe 4 to 6 hours.
Well, it seems quite short for managing ADHD all day.
It does, but interestingly, the central effects, the effects on focus and attention, seem to last longer than the plasma levels would suggest. That's why twice daily dose usually works well, 1 dose in the morning, 1 in the afternoon.
Okay, common side effects to watch for.
The main ones are things like anorexia, loss of appetite, which ties into the growth concerns insomnia, difficulty sleeping, and that potential for growth retardation we mentioned.
Right. Now let's talk about atomoxetine. This one needs its own space because the mechanism is totally different, isn't it?
Completely different. This is a critical point for professional understanding. Atomoxetine is a selective norepinephrine reuptake inhibitor, an SNRI basically, but a very specific one.
So it stops norepinephrine from being cleared away, increasing its levels, but doesn't directly cause release like amphetamines.
Exactly. And critically, it's chemically unrelated to amphetamines or even older antidepressants like imipramine. It's not a CNS stimulant in the traditional sense. It's not considered an antidepressant. And this is key. It does not enhance dopamine release. It's all about boosting norepinephrine.
And that norepinephrine boost is what helps with attention and behavior in ADHD.
That's the proposed mechanism, yes, for children over 6 and adults.
Okay, but atomoxetine comes with a significant warning flag related to how it's broken down in the body.
Metabolism. Ah, yes, pharmacogenetics comes into play here. Big time. Atomoxetine is metabolized, specifically hydroxylated, by the CYP2D6 enzyme system in the liver.
And people vary genetically in how active that enzyme is, right?
Tremendously. Most people are what we call extensive metabolizers, EMs. They have normal CYP2D6 activity, clear the drug efficiently, but a decent chunk of the population are poor metabolizers, PMs. Their CYP2D6 enzyme just doesn't work well, or at all.
So what happens if a poor metabolizer takes a standard dose of atomoxetine?
Their blood levels of the drug can go way, way up, dangerously high, increased risk of side effects, increased risk of toxicity.
It's not just about their genetics, is it? Other drugs can interfere.
Correct. If a patient is taking another drug that inhibits CYP2D6, and this includes some very common drugs like the SSRI antidepressants, fluoxetine, Prozac, and paroxetine Paxil, or the heart drug quinidine, those inhibitors will effectively turn an extensive metabolizer into a poor metabolizer functionally.
So you could inadvertently cause toxicity even in someone with normal genetics if you don't check their other medications.
Absolutely. It's a major drug interaction risk. You have to screen for CYP2D6 inhibitors. Also, clinically, it's contraindicated with MAO inhibitors and in patients with narrow-angle glaucoma.
Side effects generally.
Generally considered relatively well tolerated compared to stimulants, but common things include dyspepsia, upset stomach, anorexia again, sleep disturbances, mood swings. And there are rare but serious warnings about suicidal thoughts and potential liver toxicity, hepatotoxicity.
Okay, let's move to the next wave, maybe. Modafinil. This one has a bit of a reputation, doesn't it? Night shifts, students?
It does. Modafinil is popular, used by people trying to stay alert and focused, especially when fighting fatigue, like shift workers or even some professionals. The claim is it improves attention and accuracy when you're tired.
But how does it work? Is it like amphetamine?
That's the million-dollar question. The actual mechanism of modafinil is still kind of a mystery. We know it has some weak effects. It inhibits NMDA reuptake slightly, affects glutamate and GABA levels, but the precise pathway that produces its wakefulness-promoting effect isn't really nailed down.
Interesting. It seems to promote alertness without necessarily the same jittery feeling as amphetamines.
That's often the subjective report, yeah. Cleaner alertness, maybe?
What are its official approved uses?
They target specific sleep disorders, excessive daytime sleepiness caused by narcolepsy, by obstructive sleep apnea syndrome, and importantly, shift work disorder, SWD.
Right. And there was something novel mentioned in the source, too, about cocaine.
Yes, quite interesting. It's been looked at for preventing cocaine relapse. Some studies suggested it could reduce the euphoric high from cocaine and also help manage withdrawal symptoms.
That hints at a pretty unique interaction with the brain's reward pathways.
It does suggest potential uses beyond just sleep. Pharmacokinetically, it's got a nice long half-life, around 15 hours.
Well, that makes dosing easy.
Yeah, typically a single 200 milligram dose, about an hour before the work shift for SWD. And its sibling drug, armodafinil, the R enantiomer, is also approved for similar indications.
Okay, finally in this section, the one everyone knows. Caffeine.
The world's favorite psychostimulant, a methylxanthine.
But even though it's common, we shouldn't underestimate it. Kinetics.
Absorbed pretty quickly orally, though it can be a bit inconsistent between people. Almost completely metabolized by the liver. Plasma half-life is usually around 3 to 6 hours.
And adverse effects. Just the jitters.
Well, at low doses, yeah. Nervousness, insomnia, maybe some agitation. But toxic doses are serious. Delirium, muscle twitching, even convulsions and dangerous tachycardia, rapid heart rate. Generally less toxic than its relative, theophylline, though.
And the big warning. peptic ulcers.
Definitely. Caffeine stimulates gastric acid secretion, so it's a definite no-go for people with active peptic ulcers. Can really aggravate them.
Beyond just waking us up, what are its specific therapeutic uses?
The text highlights three main ones. First, it's often included in analgesic mixtures, like headache powders or pills.
Does it actually kill pain?
No intrinsic analgesic action itself. The idea is it helps combat the fatigue and boredom that can accompany pain, making the primary painkiller feel more effective, perhaps.
Okay. Second use.
Migraine treatment, specifically in combination with ergotamine, like in Cafragot.
Why combine them?
Two reasons. Caffeine itself causes some cranial vasoconstriction, which augments the effect of ergotamine. And importantly, it significantly enhances the absorption of ergotamine from the gut. Gets more of the ergotamine into the system faster.
Clever. And the third use.
A bit more niche. Treating apnea, periods where breathing stops in premature infants. It's sometimes used as an alternative to theophylline for this.
Interesting. The source also mentions specific combinations like micropyrin, Dolapar, and that caffeine tonics are banned in India.
Yeah, it just highlights that even common substances face different regulations globally. Context matters. Okay, so now we pivot to arguably the most challenging area we're covering today, the cognition enhancers.
Yeah, this feels like a different ballgame. We're not just tweaking neurotransmitters for focus, we're trying to tackle progressive neurodegeneration.
Exactly. The goals are often different too. Maintenance, slowing decline rather than outright cure, which sadly isn't really on the table yet for most conditions here.
Let's start with the definition. What exactly is dementia?
It's defined as an acquired global impairment. Affects intellect, memory, and other cognitive functions, things like comprehension, orientation, judgment, problem solving.
But crucially, without gross clouding of consciousness. It's not delirium.
Right. The defining feature is that these impairments are severe enough to interfere with daily living, social functioning, emotional control.
And the most common cause, by far, is Alzheimer's disease.
AD. AD is the big one. A progressive neurodegenerative disorder primarily affecting older individuals. To really grasp the challenge of treating it, you have to understand the pathology, what's actually going wrong in the brain.
We see brain atrophy, shrinkage, right, in cortical and subcortical areas.
We do. But the microscopic hallmarks are the key. The two infamous signs of AD. First, you have the extracellular senile plaques. These are clumps of sticky protein called amyloid, or AO, accumulating outside the neurons.
Yeah, plaques outside. What's the second sign?
Inside the neurons, you get intracellular neurofibrillary tangles. These are twisted fibers made mainly of a protein called tau.
Tau protein. What does tau normally do, and why does it get tangled in AD?
Normally, tau protein is crucial for stabilizing the neuron's internal skeleton and transport system, the microtubules. Think of them like railway tracks inside the cell, moving essential cargo.
Okay.
In AD, tau protein becomes abnormal, specifically hyperphosphorylated. It changes shape, detaches from the microtubules, and clumps together inside the neuron, forming those tangles.
So the railway tracks fall apart.
Essentially, yes. The transport system collapses. Nutrients, components, signals can't move effectively within the neuron. This leads to dysfunction, and eventually the neuron dies.
And combining the damage from external plaques and internal tangles leads to a major neurotransmitter deficit.
The primary one, functionally speaking, is a marked cholinergic deficiency, a loss of acetylcholine ACO signaling, though other systems like glutamate and various neuropeptides are definitely affected too.
This cholinergic deficit is why so many treatments target that system.
It became the most logical starting point, yes. But we need to inject a strong dose of realism here, which the source material does.
The outlook isn't great.
The indications for cognition enhancers are broad AD, vascular dementia, multi-infarct dementia, mild cognitive impairment, MCI. Even things like learning defects or stroke recovery are sometimes targeted. But the actual therapeutic landscape for many of these, especially beyond the core AD drugs, is described bluntly as barren.
Barren, but profitable.
Highly profitable commercially because the need is immense. Millions suffer from these conditions. But the actual clinical benefits, even from the best available drugs for AD, are often quite limited and don't last forever. They don't stop the disease.
So we need professional skepticism about claims of major breakthroughs.
Intense skepticism is warranted, especially when looking beyond the established mechanisms.
Which brings us to the claimed mechanisms for some of these enhancers. The source lists 4 common ones.
Right. The typical claims you hear are: 1, they increase cerebral blood flow, CBF, either globally or regionally. 2, they directly support neuronal metabolism. 3, they enhance neurotransmission, which is valid for drugs like the cholinesterase inhibitors. And 4, they somehow improve specific brain functions like memory directly.
Let's spend a minute on that cerebral blood flow claim.
Yeah.
It sounds intuitive. More blood flow to the brain must be good, right? Especially if there's damage.
It sounds intuitive, but it's often based on a flawed assumption, particularly for dementia and stroke. Many drugs were tested based on the idea that selectively boosting CBF would help.
But the evidence doesn't really support it.
Often, no. Precise measurements show either the drugs don't actually increase CBF much, or worse, if they cause global vasodilation, opening up blood vessels everywhere in the brain, it can actually be harmful.
Harmful how? This is the Steele phenomenon, isn't it?
Exactly. Let's explain that because it's crucial. Imagine an area of the brain affected by a stroke or ischemia. The blood vessels supplying that damaged tissue are already maximally dilated. They're screaming for blood.
Okay, they're wide open trying to compensate.
Right. Now, you give a drug that non-specifically dilates blood vessels everywhere in the brain. What happens? The healthy areas where vessels weren't fully dilated now open up wide, too.
Ah, so blood flow takes the path of least resistance.
Precisely. Blood gets diverted or stolen away from the already struggling, maximally dilated ischemic area and flows instead to the newly opened healthy areas. This can actually worsen the damage to the vulnerable tissue.
And in Alzheimer's, the reduced blood flow might just be because the neurons have died off anyway.
That's the other critical point. In AD, reduced CBF is very likely a consequence of neuronal loss and reduced metabolic demand, not the root cause of the degeneration. Dead neurons don't need much blood. Simply forcing more blood flow isn't going to bring them back to life.
So that whole increased brain blood flow strategy is largely discredited for dementia.
For dementia, yes. It's a fundamentally shaky rationale for most agents promoted that way.
Okay, so if increasing blood flow isn't the answer, let's get back to that primary deficit in AD, the loss of acetylcholine.
Right. The logical strategy, given the known cholinergic deficiency and the loss of the enzyme that makes cholinacetyltransferase, was to try and boost the levels or effects of the AC8 that's still being produced by surviving neurons.
Makes sense. But the early attempts didn't go so well, did they? Trying to give precursors like choline or lecithin.
No, that failed. The problem wasn't really a shortage of the building blocks, choline. The issue was the loss of the factories. The neurons containing choline acetyltransferase needed to assemble AC. Giving more bricks doesn't help if the bricklayers are gone.
And what about using older conventional anticholinesterase drugs, like physostigmine, drugs that stop AC breakdown?
Physostigmine did show some brief glimmers of cognitive improvement in trials, proving the concept that boosting AC could help symptomatically, but it was clinically impractical.
Side effects.
Massive peripheral cholinergic side effects. Physostigmine doesn't just work in the brain, it boosts AC everywhere. So patients got severe nausea, vomiting, diarrhea, cramping. The side effects were intolerable at doses needed to get enough drug into the brain to have a cognitive effect.
So the goal became developing anticholinesterases that were more selective for the brain, or at least better tolerated.
Exactly. The first one developed specifically for AD was tacrine. It was centrally acting.
But we don't use tacrine anymore, right?
No. It worked somewhat, but it turned out to be quite toxic to the liver hepatotoxicity, so it was withdrawn. That led to the development of the modern generation of anticholinesterases.
The main ones we use today. Let's start with rivastigmine.
Okay. Rivastigmine is chemically a carbamate derivative. It's interesting because it inhibits both major cholinesterases found in the brain, acetylcholinesterase, ACE, and butyrylcholinesterase, BUSHI.
Does inhibiting BUSHI add anything extra?
It's thought that BUSHI might play a more significant role in breaking down HE in the later stages of AD as ACE levels decline, so inhibiting both could potentially offer broader or longer-lasting benefit. Rivastigmine is also highly lipid-soluble, so it gets into the brain easily, and it shows some selectivity for a specific form of HE, the G1 isoform, which might be more concentrated in vulnerable brain regions.
No, there's a really key pharmacokinetic point about rivastigmine. Its plasma half-life is short, like 2 hours, but its effect lasts much longer, up to 10 hours. How does that work?
This is down to its mechanism of enzyme inhibition. It's often called pseudo-irreversible. When rivastigmine binds to the cholinesterase enzyme, it transfers part of its molecule, a carbonyl residue, onto the enzyme's active site.
Okay, so it modifies the enzyme.
It does, and that carbonyl group dissociates or falls off very slowly. It takes hours for the enzyme to become active again. So even though the rivastigmine drug itself is cleared from the bloodstream relatively quickly, the enzyme remains inhibited for a much longer duration because it's been chemically tagged, essentially.
That explains the prolonged effect despite the short half-life. Clinically, what kind of benefit does it offer?
The benefit is modest, but measurable. On average, studies show about a 3.8-point improvement on the ADS-COG scale, a common Alzheimer's assessment, compared to placebo. It can help not just with cognition, but also with some behavioral symptoms like apathy, delusions, hallucinations, maybe agitation to a lesser extent.
But the big limitation.
It does not stop the underlying disease progression. The plaques and tangles continue to accumulate. It's symptomatic relief. The good news is it's not associated with the liver toxicity seen with tacrine.
And it's used for mild to moderate AD, available as capsules and patches.
Yes, the transdermal patch formulation can be helpful for reducing gastrointestinal side effects.
Okay, next up, Donepezil, probably the most well-known one.
Quite possibly. Donepezil is described as a cerebroselective and reversible anti-ADIG.
Reversible, unlike rivastigmine's pseudo-irreversible action.
Correct. It binds and unbinds more readily. Its benefit is thought to come from boosting ACE levels primarily in the cortex and hippocampus, supporting those crucial surviving cholinergic neurons projecting from the basal forebrain.
The big selling point for Donepezil seems to be its pharmacokinetics, right?
Absolutely. Its major clinical advantage is its incredibly long plasma half-life, around 70 hours.
70 hours? That's almost 3 days.
It is, which means you can dose it just once a day, usually at bedtime. This is a huge plus for patient adherence, especially in an elderly population where managing multiple daily pills can be difficult.
But that long half-life must have a downside, too.
It does. If a patient experiences side effects, they're going to last for several days after stopping the drug because it takes so long to clear. So initiating therapy requires careful consideration. It also means dose adjustments need to be made slowly.
How's its tolerability generally?
Because it's more selective for brain AC and has weaker peripheral effects compared to something like rivastigmine, the cholinergic side effects are usually milder. It's generally well-tolerated, not hepatotoxic, and can be used even in more severe stages of AD than perhaps originally thought.
Okay, and the third main player is galantamine.
Galantamine is interesting because it's a natural alkaloid originally derived from snowdrop bulbs, I believe, and it has a dual mechanism.
Dual mechanism. How so?
Like the others, it selectively inhibits cerebral AC. But in addition, it seems to have some direct agonistic action at nicotinic acetylcholine receptors. It modulates them in a way that might enhance cholinergic function further.
So it stops AC breakdown and directly tickles another type of AC receptor.
That's the idea. Two complementary actions. In terms of efficacy, the cognitive and behavioral benefits are considered comparable to rivastigmine and Donepezil.
Any drawbacks?
The main one compared to Donepezil is that it needs twice daily dosing due to a shorter half-life.
Okay, so let's synthesize this cholinergic strategy. We have 3 main drugs: rivastigmine, Donepezil, galantamine.
Right. They all offer similar, modest, symptomatic benefit. They can slow cognitive decline or stabilize function for a period, typically 6 months to a year maybe. In some patients, maybe about 50% of those with mild to moderate AD see a measurable response.
But they don't stop the disease.
Critically, no. The underlying neurodegeneration continues.
And there's a clear guideline about when to stop therapy.
Yes. The consensus is that if there's no observable clinical benefit after a reasonable trial period, typically around 3 months, the drug should be discontinued. There's no point exposing the patient to potential side effects without benefit.
And those side effects are mostly predictable cholinergic ones.
Largely, yes. Diarrhea, nausea, loss of appetite, anorexia, sometimes muscle cramps or pain, fatigue, weird dreams, occasionally insomnia or even hallucinations in some sensitive individuals. It's all related to boosting acetylcholine activity.
All right. If the cholinergic approach provides only modest temporary benefit, what else is there? Let's look outside that system. Memantine comes up next.
Memantine represents a completely different strategy. It targets the glutamate system, specifically the NMDA receptor.
Glutamate, that's the main excitatory neurotransmitter, right? Why would you want to block excitation in a disease like Alzheimer's?
It's about excitotoxicity. While normal glutamate signaling via NMDA receptors is vital for learning and memory, the theory in AD is that there's a chronic low-level overactivation of these receptors due to the disease process. This constant excessive stimulation is thought to be toxic to neurons, contributing to their death.
So Memantine tries to dial down that harmful overstimulation.
Exactly. It's an NMDA receptor antagonist chemically related to amantadine, which is used in Parkinson's.
But how does it block the bad NMDA activity without blocking the good, necessary activity needed for normal function?
That's the clever part of its design. Memantine is described as a non-competitive and use-dependent blocker. Non-competitive means it doesn't directly fight glutamate for its binding site. Use-dependent is the key.
Use-dependent, meaning?
It means Memantine preferentially enters and blocks the NMDA receptor channel only when it's already open, particularly when it's open frequently or for prolonged periods, which is characteristic of that pathological excitotoxic state. It doesn't block channels that are just opening briefly for normal signaling as effectively.
So it acts like a smart gatekeeper, only blocking the channel when it's being pathologically overused.
That's a good way to put it. It dampens down the toxic noise while hopefully allowing the normal signal to get through.
And clinically, where does Memantine fit?
It's primarily shown benefit in moderate to severe Alzheimer's disease. It seems to slow down the rate of functional decline in those later stages. Its benefit in milder AD is less clear or established.
How does it compare to the anticholinestrases in terms of side effects?
Generally, Memantine is considered better tolerated. Side effects can include things like dizziness, headache, confusion, or constipation, but often less problematic than the cholinergic side effects for many patients.
So it can be used instead of an anti-Chi if those aren't tolerated.
Yes. Or, increasingly, it's used in combination with an anticholinesterase in moderate to severe AD, tackling the disease symptoms through two different mechanisms simultaneously. It's also sometimes used off-label for other types of dementia.
Okay. Now, we venture into the territory labeled nootropics. This sounds potentially controversial.
Yeah. This is where the evidence often gets much thinner and the marketing claims get much louder. Piracetam is kind of the classic example.
Piracetam, what is it chemically?
It's a cyclic derivative of GABA. But interestingly, despite looking like GABA, it doesn't seem to have any GABA-like activity in the brain.
And it was called a nootropic. What does that even mean?
The term was coined to suggest a drug that selectively improves higher brain functions, cognition, learning, memory, without having other stimulant or sedative effects. Piracetam was claimed to improve these higher telencephalic integrative activities.
Sounds impressive. What were the actual claims for its use?
Oh, they were broad. Widely promoted for all sorts of cognitive impairment, age-related memory decline, mental retardation in children, dyslexia, you name it.
Okay, but what does the rigorous scientific evidence say? Our source mentions a Cochrane review.
Yes, a key 2004 Cochrane systematic review looked at all the available high-quality trial data. Their conclusion was pretty blunt. The published evidence does not support the use of piracetam for cognitive impairment or dementia.
So the claims outstrip the proof.
By a significant margin, professionals need to be aware of that discrepancy. In the UK, for example, its only approved indication is very narrow, as an add-on treatment for cortical myoclonus, which is a specific type of muscle jerking, not for general cognition.
Are side effects an issue?
Generally considered minor things like stomach upset, nervousness, maybe some excitement. The main issue is the lack of proven benefit for its widely promoted uses.
And this pattern seems to repeat with other agents. Pyridinol or pyridoxine?
Right. Pyridinol is basically two vitamin B6 pyridoxine molecules stuck together, although it doesn't have vitamin B6 activity itself.
And the claims?
Claimed mechanisms included increasing glucose transport into the brain and improving blood flow in ischemic areas. It was pushed for recovery after stroke or head injury, developmental issues in kids, memory problems.
But the reality?
Therapeutic benefit remains highly uncertain. And concerningly, it's been withdrawn in some places due to risks of serious adverse reactions, including immunological ones. Again, weak evidence, potential risks.
Dehydroergotoxin, also called codagocrine. This one sounds like an ergot derivative.
It is. Semisynthetic ergot alkaloid. Its main property is blocking alpha-adrenergic receptors.
Ah, so back to the blood flow idea.
Exactly. The claim was it selectively increased cerebral blood flow and somehow protected brain metabolism. Same flawed premise we discussed earlier.
Recommended for MCI and dementia, but value not established.
Correct. Therapeutic value is unproven. And the side effects are typical alpha blocker effects, flushing, headache, postural hypotension, dizziness on standing up, which can be particularly problematic in the elderly.
Okay, quickly then, pyribital.
This one's a dopamine agonist. Claims were around improving memory, concentration, vigilance, even helping with giddiness or tinnitus supposedly caused by poor circulation. Benefit. Unsubstantiated.
Citicoline. Sounds like choline.
It's derived from choline and citidine, and it is involved naturally in making phospholipids like lecithin important for cell membranes.
So the claim is it helps rebuild brain cells or improve metabolism.
Claims are around improving function by boosting CBF and enhancing cerebral metabolism. Some studies show maybe short-term improvement after stroke, but overall, there's little convincing evidence for sustained cognitive benefit in dementia. Yet it's very widely prescribed, often due to heavy marketing pressure.
Which brings us to the herbal supplement everyone asks about, ginkgo biloba.
Ah, ginkgo. The active components are thought to be ginkgo-flavon glycosides, like ginkgolide B.
And the proposed mechanism.
Ginkgolide B has antagonistic action against platelet activating factor, PAF. Since PAF is involved in inflammation and blood clotting, thrombosis, the rationale was that blocking PAF might help prevent brain impairment, perhaps related to vascular issues.
Plausible theory. What did the big reviews find? Another Cochrane analysis.
Yes, a 2007 Cochrane meta-analysis looked at ginkgo for cognitive impairment and dementia. It concluded that while some trials showed minor improvements, the overall evidence was inconsistent and unreliable. No convincing proof of significant benefit.
And any risks with ginkgo?
Side effects are usually mild, some upper GI upset. But the important one, because of that anti-PAF effect, is an increased risk of bleeding. Should be used cautiously, especially with blood thinners. #outro Livell effect. So looking back, we've covered a huge range. It's been quite a journey, hasn't it? From incredibly specific molecular poisons.
Yeah, like strychnine precisely blocking glycine at that Renshaw cell junction, explaining that terrifying symmetrical seizure.
Or picrotoxin acting non-competitively, allosterically, to jam the GABA chloride channel from the inside. Very defined mechanisms.
Then we moved into the more targeted, but still broad manipulation of key neurotransmitters with the psychostimulants.
Right, contrasting the dopamine-norepinephrine releasing action of methylphenidate with the pure norepinephrine reuptake inhibition of atomoxetine.
And hitting those crucial practice points, like the CYP2D6 polymorphism risk with atomoxetine. You have to know about that.
Absolutely. And finally, we landed in the really complex, often frustrating world of cognition enhancement.
Where the best we have for Alzheimer's, like Donepezil, offers only modest symptomatic help by boosting the remaining acetylcholine.
But fundamentally doesn't stop the tau tangles or amyloid plaques. The professional understanding has to include that limitation. It's management, it's slowing things slightly for some, but it's not a cure or prevention.
That stark difference between a drug with a powerful, predictable effect like strychnine and one with modest, symptomatic, temporary benefit like Donepezil, that distinction is absolutely core to mastering this field, isn't it?
It really is, knowing what the drug actually does, how well it does it, for how long, and what its limitations are.
Which brings us right back to the sharp end of clinical practice. That case study example from the source material really highlights the dilemmas.
Let's put it to you, the listener. Imagine that 75-year-old patient with moderate Alzheimer's. They've just started Donepezil. It's only been a week.
Okay, 1 week in.
Zero noticeable improvement in cognition yet. But they are experiencing severe, really bothersome cholinergic side effects, bad diarrhea, muscle aches, so bad they're starting to refuse the medication.
So you're faced with this immediately. We know the guidelines say try for 3 months before concluding no benefit.
Right. But Donepezil has that 70-hour half-life. These side effects aren't going away quickly, and statistically, maybe only 50% of patients get a benefit anyway.
So what's the clinical calculation? What pathway do you weigh right now?
Do you push through? Tell the patient and family to endure potentially weeks more of these significant side effects, hoping for a benefit that might not come, just to meet that 3-month trial guideline.
Or do you switch immediately? Maybe try rivastigmine or galantamine, hoping their different kinetics or maybe slightly different receptor profile might be better tolerated.
Or, given the patient has moderate AD, do you pivot strategy? Maybe stop the anticholinesterase now because of the side effects and introduce Memantine instead. Or even consider adding Memantine on top of the poorly tolerated Donepezil, hoping the combined mechanisms might offer benefit despite the side effects.
Each path has risks and potential benefits. It's not just about knowing the drug names.
It's about integrating the mechanism, the kinetics, the evidence for efficacy, the side effect profile, the stage of the disease, and the patient's tolerance and values. It's a real test.
A true test of pharmacological reasoning and clinical judgment. Definitely something to think about as you apply this deep dive material.
Indeed.
Thank you for joining us for this deep dive.